Okay, so thanks once again, Rose, for the invitation to speak today. I've got a number of different roles, but I'm Professor of Medicine at the University of Otago in Christchurch. I'm a gastroenterologist at Te Whatu Ora Waitaha, or CDHB. I'm also a trustee of the Gut Foundation, which I think is how you found us in the first place, Rose. So
Yes.
just a shout out to them as well. So a number of disclosures, often at the start of us about commercial or conflicts of interest, but probably the first disclosure I have, which will make you all go running away and not listen to what I have to say, is that I've got no specific expertise in MECFS. So I don't pretend to be an expert, but I do have expertise in a lot of gut problems, including inflammatory bowel disease, functional gut disorders, the microbiome, and all that. And actually, I must say that I've learned so much in a short period of time about something I didn't know anything about as preparing this presentation. So what this presentation is going to do essentially is go to the gut, what's going on in the gut. I'm going to talk a wee bit about inflammatory bowel disease, a wee bit about IBS, then I'm going to start to talk about the microbiome, and then about MECFS and the microbiome. It'll give you an understanding about where the research is and where we might go. Sorry, Rose.
Oh, you just cut out for a second there, but I don't know. Well, I think we just need to
The other
persevere, don't we? Yeah.
I might stop my video because that will reduce the amount of stuff going through. Okay.
Yeah.
So this is a tour through the gut in reverse, just to give you an idea about where we are. We're starting at the bottom, going around here. Quite real. If I'm doing a colposcopy, it looks like this. And then it goes through into the intestine. And then into the stomach. So that's sort of where I go to work. And people think that as a gastroenterologist, it's a big part of what we do. And it's pretty healthy. So this is the gastroenterologist. I just want to take you through this just to orientate you to the gut and what's going on. So at the top here, we can see the esophagus. So the esophagus is how we get food from our mouth to our stomach. And the sorts of things that can go on there that might cause trouble would be reflux. So if the contents of the stomach go up into the esophagus, that causes burning and reflux. And people can also get esophageal cancer, which isn't that common. So that's the esophagus. Next part, the stomach. The stomach is essentially a great big liquidizer. So it's like the bit that you put on top of your food processor to make the food turn into chyme or liquid. And the things that can go wrong there include ulcers, infections with Helicobacter pylori, and cancers. So they're the sorts of things we look at there. The small intestine's the bit in the middle. That's where digestion occurs, and that's where nutrients and fluid are absorbed. And there's contraction that pushes things through there. And you will have heard of celiac disease and Crohn's disease, both of which can affect the small intestine. And if we look at celiac disease for a brief moment, that affects about 1 in 80 people. There's a genetic predisposition to celiac disease, and then the environmental factor and a trigger means that people become allergic or intolerant to gluten. And the next slide shows 2 slides from biopsies of people from the small bowel of people with celiac disease. So on one on the left is normal. The one on the left, you see those long finger-like projections of the mucosa. These are the villi. They increase the surface area for absorption. On the right here, you can see those villi have gone and it's flat. And that shows celiac disease, and that's the difference that you see in that condition. Colon, that's the last bit of the bowel, and that's where water and salts get absorbed, and that's where we can delay defecation if we need to enable people to pass a bowel motion when they need to. And sorts of things that we look at there are colitis, colorectal cancer, and diverticular disease. Just to put some of those in perspective, you will have heard of colonic polyps. So polyps start off as little wee, almost like warts, if you like. And slowly they can change into becoming more malignant and invasive, if you like. And we're always looking for polyps when we do colonoscopies and also bowel cancer. And we've got lots of bowel cancer in New Zealand, and it's not related to this talk in particular, but I can't do a talk without saying how important it is to make sure that if you have a change in your bowel habit, that your doctor knows about it. So I'm going to talk very briefly about IBD and IBS. I know that this isn't MECFS, but I just wanted to really go through this because there's a lot of these mirror, I think, what goes on in IBS a little bit. So a lot struggle with the difference between IBD and IBS. So IBD is Crohn's disease and ulcerative colitis. It's about 3,000 to 4,000 Cantabrians. The bowel looks like this one here. IBD. About IBD is where people get they have just very triggered by yes, of course, pretty normal, and it looks like it's people now. You can see there. So talking a bit about IBS now, and IBS has got some big overlaps with MECFS, as many of you will know, but this sort of puts it in perspective for functional lower gut disorders. So on the left axis, you can see constipation, and on the right axis, diarrhea, and then pain along the bottom. And people with IBS have got pain and then have either constipation or diarrhea, or it's mixed. And some people can have constipation or diarrhea without pain as well, but that's the sort of functional lower gut disorders where the bowel looks normal, but people have symptoms of pain and change in bowel habit. So many of you might know about a place called Bristol. It's a beautiful place in Western England. And the reason I know about Bristol is because of this thing here called the Bristol stool chart. So this is how we describe bowel motions. I'm a gastroenterologist, so I can say this and not laugh. But essentially you can see type 1, type 2 bowel motions, which are hard, going through to the more 6, 7 ones, which are more watery or loose, if you like. And people have diarrhea or constipation with this. And irritable bowel syndrome has chronic symptoms. There's a lot of variability day to day. Typically, the symptoms go to sleep when patients do, and then they wake up in the morning and the symptoms are gone. Some people feel as though they can't empty their rectum fully, and some people don't have alarm symptoms like bleeding or nocturnal symptoms or weight loss, which are much more worrying. And it's really common. So 1 in 6 women and 1 in 9 men will have IBS. So it's much more common than IBD. So people with IBS have got a reduced quality of life. They don't go to work and school so much. They go to the doctor more often. And there is this association with other disorders that we'll talk about a little bit later, including depression, anxiety, migraine, fibromyalgia, and chronic fatigue. But there is no increased risk of bowel cancer or a reduction in lifespan because of the IBS, if that makes sense. So why do people get symptoms if their gut looks normal? I showed you before a colonoscopy of someone with a normal bowel and said that that person could have IBS. So how can it be that a normal looking bowel can cause symptoms? Well, inside your gut, there's a second brain, and some of you may know about this, which is that there are almost as many nerves in your gut as there are in your brain, and that this is very, very active in controlling what we feel within our gut, and also can affect our gut directly. So some of you may be aware of this thing called the gut-brain axis. The neurologists I know call it the brain-gut axis, but they're wrong, because obviously gastroenterologists have to be right, not neurologists. So what you can see here is that the brain can send signals to the gut, and that can affect motility, or the way that the gut pushes things through. It can affect secretion, nutrients, and even the bugs in the gut can be affected by what's going on in the brain. However, the gut can affect neurotransmitters that live in the nerves, can affect stress and anxiety, mood and behavior. So you've got this feedback that goes both ways between the gut and the brain. And then just to make things really complicated, we've got the microbiome, which I'm going to talk about soon, sitting in here as well. And this is all of the environment, if you like, that tells us what can be going on with gut symptoms. So here's a cross section through the gut. So the inside of the gut is this bit in the middle here, and you can see the villi that increase the surface area of the gut. And the yellow bits are all the nerve plexuses which go through different areas of the gut. And these plexuses send signals downwards, but also are taking signals back to the brain. And it's this interaction that can lead to a lot of the symptoms that we see in people with IBS. So just to put that in perspective, all the neurotransmitters that are in your brain are also in your gut. And serotonin, which is a really common neurotransmitter that many of you will have heard of, actually 95% of the body's serotonin is actually in the gut. In addition to that, you get communication via hormones. The microbiome can alter serotonin, and it's a two-way street. So 90% of the nerve fibers that go from the brain to the gut actually go the other way. So this is a really complicated thing. And one of the problems we have, of course, as specialists is that I'm a gut specialist, but I've got to learn about this other stuff as well. And we're not necessarily trained in this way, if that makes sense. And there's actually a subspecialty called Neurogastroenterology to try and put these two things together. There's also this other thing called post-infectious IBS, which I think is really relevant for MECFS, because we know that that if someone gets a gut infection with Campylobacter or with another bacteria or a virus, that about 1 in 5 people who get that infection will get ongoing symptoms, often mixed diarrhea, constipation, or diarrhea that can continue after the infection's gone. So the infection sets off the normal response to the body with diarrhea, but then it's almost as though the body then says, "I knew normal." And even though the infection's gone, I'm going to continue to give you abdominal pain, diarrhea, and bloating and constipation. And that's a post-infectious IBS, which of course does have some mirrors to some of the theories and some of the observations in the MECFS population as well. So you can see here, there are these similarities, if you like, between these conditions. So just to try and put this together, and this isn't easy, and I just want to try and just demonstrate the interactions that are occurring. In the middle, you can see a line of cells with the inside of the gut at the top and the outside of the gut at the bottom. Inside the gut in the lumen, you've got food, you've got the microbiome, which we'll get onto in a minute, you've got bile acids interacting with the gut, and on the inside, you've got the immune system that's working through nerves, you've got other nerves working in the mucosa that are linked to the brain. So all this is going on in IBS, and in fact, what we'll learn soon is it's also going on in MECFS. So this is one of many slides or diagrams that makes you think about why people might get IBS. So there might be a prior infection, there could be psychological stress, we've got the gut-brain axis going on, we've got diet and food sensitivities, we've got early childhood factors and gut flora changes. And of course, many of the things that you can see on here have also been implicated in MECFS. So there are some similarities. So how is this different to IBD? I've spoken about IBS today, but IBD is where you get all that nasty inflammation in the bowel. So this is IBD here. This at the top. It's about 3 different people compared to what I showed you before. And people get very powerful, treatment, surgery, control. In New Zealand, we've got very high rates of Crohn's disease. So the black line there is Canterbury, and we've got one of the highest rates of Crohn's disease anywhere in the world. And you can see here that the age of incidence, so when people are usually die, usually between that sort of 15 to 45-year-old age group, mostly. So we've got a lot of IBD in Canterbury. So why so much IBD? Well, genes are part of the reason. So there is a family history part to this, but clearly something in the environment has made this much more common than it used to be. So my simplistic way of thinking about it, on the left, we've got the intestine, and on the right, we've got the body. And in the intestine, there are trillions of bacteria, trillions and trillions of bacteria. And if those bacteria were anywhere else in the body, your body would be very unhappy. But in the gut, the body is so it interacts with the immune system, get tolerance. So it's a bit like the Dalai Lama. In health, the body is very tolerant of all these bacteria that live in the gut. However, in IBD, or maybe different bacteria, but when they interact with the immune system, and I've got a picture there of Paul Henry, which maybe is a bit mean on Paul, but I think he's well known for being perhaps a bit less tolerant than other people. So that's an IBD, you've got this loss of tolerance, and that gives that inflammation. And there's lots of, don't look at this in detail, there's lots of genes behind this that predispose, and most of those genes are all about how the gut and the microbiome interact. We've done lots of papers in that space. So in IBD, we think, well, the immune system's important, there are some genes and there are some environmental triggers. But in fact, it's actually a bit more complicated by this. And again, this slide, I think, is quite important for many Western diseases or modern diseases that we see nowadays. So back in the old days, where we've got our caveman friend at the top there with his fire, and if you look inside his gut, he had a gut with lots of diversity, lots of different bugs, all sorts of things going on. And in that lifestyle, there's no refrigeration, no antibiotics, no chlorination, there's breastfeeding everywhere, not just for some people, and unrefined foods, fermented foods, etc. And now in the Western world, we have all these changes that potentially have changed and reduced the diversity of bacteria in our gut, which potentially could increase the risk of inflammatory conditions and these sorts of things, which maybe could include MECFS. So in fact, there may be many potential risk factors that could predispose to IBD, and I suppose many of these things may mediate through the microbiome. So these environmental risk factors for IBD, breastfeeding, childhood hygiene, antibiotics, diet, appendectomy, smoking, all potentially work through the microbiome. So the microbiome is the bugs that live within us that call us home. And if we look at that in a bit more detail, actually, if we counted up all the cells in our body, there are more microbial cells in our body than there are human cells in our body. And that's an interesting fact. It's a good takeaway, general knowledge fact that we're more bug than we are human. So 100 trillion bacteria, fungi, protozoa, and viruses live on and inside us. But those bacteria are so important to us. They play a really important role in keeping us well. So they allow us to extract energy from food. They produce vitamins for us. They regulate our immune system. They regulate glucose metabolism, can protect us against other bugs. And we have what we call a symbiotic relationship where these bugs, actually, we provide them with a home and they do some cool stuff for us as well. But there has been changes in that microbiome over time as diet changes and other influences in our life change as well. Now, if you have bugs in your gut, then which we all do, many of the things that we eat aren't readily digestible. And particularly these are carbohydrates. So some carbohydrates aren't digestible. They go through into the colon. And these bacteria that live in the colon produce these wonderful things called short-chain fatty acids. It's a bit of a mouthful, but it's an important thing to remember. So short-chain fatty acids are wonderful. So they do all these good things for us. They reduce our appetite. They increase fatty acid oxidation. They make insulin work better. They work on a range of things within our body to really help and are really beneficial for us. So making lots of short-chain fatty acids is a really good thing to do. And just remember that, because I'm going to talk about that a little bit later when it comes to MECFS, which has got a difference in the way that this is done. So to put it another way, we've got all these trillions of bacteria on the inside, but each one of us is unique. So it's a bit like a fingerprint. Each one of us has got a slightly different fingerprint. And even though the different types of bacteria that are there may be similar, they'll be different in different concentrations for each of us. And that'll be determined by things like whether we're breastfed or not growing up, whether we've had antibiotics or not growing up, the sorts of diets that we're on, medications we may take, and a whole range of other factors that we probably don't fully understand can change our microbiome. So when we think about all the different organs in our body, what I'd say to you is that the last internal organ isn't human, it's probably microbial. And I think that's pretty cool because that is something that we could potentially alter and it could have an effect on disease and health. Okay, so we've got here in the little blue circle all the numbers of genes in the human body, 23,000 genes. If we think about all those bacteria, there's another 1 million genes there. And then if we think about all the proteins and metabolites they can make, we can measure all of those things now in humans. And by measuring those things, we can look for differences between people with diseases and people without diseases to see, are the bacteria the same? Are the genes the same? Are the proteins the same? And that might give us a clue as to why people get some diseases and not others. So you might say, well, that's all very interesting, but I came here to learn about MECFS, and what the hell are you talking about? So I'm going to try and now bring this back to MECFS to put this in context so that we can think about, well, how can things like IBS, how can things like the gut-brain axis, how can things like the microbiome be something that might be relevant to something that I'm more interested in that affects me more directly? So this is a diagram from Nature Reviews. So this is like a review on IBS, trying to put into context what IBS is, but also the other things that go with IBS. So because it's about IBS, IBS is in the center, and the different sorts of IBS. But on the outside, there are some other things going on as well that people can get that aren't strictly part of IBS. But then outside of that, there are some things outside there like chronic fatigue, pain syndromes, dysfunctions, bladder, prostate, pelvic, food intolerances, with other things as well, just showing that these things all tend to go together. And if you look online, we can see articles like this in the lay press: irritable bowel syndrome and chronic fatigue syndrome. What's the connection? And it's a nice short read, good, nice, interesting stuff that's been checked off. So that's a good read as well. But if we start to look at some of the studies now, what I'm going to do now is look at scientific studies that have been published, trying to pull out of those exactly what things have been shown and what the limitations on their observations are. So this is a pretty cool study called, it was called Irritable Bowel, Chronic Widespread Pain, Chronic Fatigue and Related Syndromes are Prevalent and Highly Overlapping in the General Population. So this study was done from Denmark. And what they did is they found 1,590 Danes, and they were screened for a range of functional somatic syndromes, body distress syndrome, IBS, widespread pain, chronic fatigue, whiplash. You can see the numbers there. But what they found that there was enormous overlap between these conditions, and that you're much less likely to have one by itself than you are to have them combined. And they drew these beautiful pictures here, showing all the people here, then those with then women here and men here, showing that these different circles are basically the different ones of these conditions, showing the overlap between them and how that works. And what that suggests is that these conditions that I just mentioned tend to coexist together, and this coexistence may suggest that there's an underlying cause that might link them all together, if you like. But this isn't new. So right back in 2000, Leslie Aaron did this study, which is published in Archives of Internal Medicine, a really highly respected journal, where she looked at people who had different diagnoses. So these diagnoses were chronic fatigue, fibromyalgia, temporomandibular joint dysfunction, IBS, and then a range of other things. And what you can see here, these are the people who had chronic fatigue. These are the people who had fibromyalgia. These are the people who had temporomandibular joint dysfunction. And these people had none of those things. They were controls. And what you can see is that the rate of other ones of these conditions are much higher if you already have one of these than if you have none of these, suggesting that these things cluster together in this way. So this isn't a new observation. It's something that's been known about for a while. And again, here's this post-infectious thing going on, which I think is really interesting. So again, this is a study, I think, from Finland that was published just last year. And they went back and found people who had Giardia 10 years ago. It was a Giardia outbreak in, I think, Bergen or somewhere in Finland or in Sweden. And then they followed these people up over time to see, well, what happened to these people? Did they develop any new or different conditions over time? And if so, did they overlap? So at the top, down the bottom here, these are controls. So these are people who didn't have Giardia, and they looked to see, well, yes, some developed IBS, some developed chronic fatigue, some developed fibromyalgia. If you've got an infection with Giardia, you'll see here if you've got an infection with Giardia, you'll see here the overlap between chronic fatigue and IBS is way, way greater. There's more people with both than there are with chronic fatigue by themselves, and likewise with fibromyalgia, suggesting that perhaps this infectious background or trigger may be more likely to have this clustering of conditions occurring together. And again, here's a similar study that's looking at fibromyalgia, but these things are linked, and trying to work out, could the gut microbiome and the gut-brain axis be the link between IBS and fibromyalgia? So it's been observed that these things coexist together. So could it be the microbiome and the gut-brain axis that links these things? And I mentioned before how the gut microbiome metabolizes carbohydrates, CHO, into short-chain fatty acids. And these short-chain fatty acids are really, really good things for the gut. They're really important. They're anti-inflammatory. They modulate stress. They modulate behavior and pain. And we know that many inflammatory diseases and conditions are associated with what we call dysbiosis, where the microbiome isn't quite how it should be, and that may change short-chain fatty acid production. So what they did is they looked at people with fibromyalgia, they looked at IBS and tried to see, if you look at all the studies, can you determine what happens to these different types of bacteria in these conditions? And you'll see that these different broad groups of bacteria either produce neurotransmitters, produce butyrate, which is a short-chain fatty acids, all these ones here, digest fiber, and produce bile acids. And what you can see is that if you look at the microbiome of people with fibromyalgia and the microbiome of people with IBS, you tend to get things occurring in the same direction. Apart from these two down here, you tend to get reductions and changes occurring in the same way, suggesting that changes in the microbiome may underlie both of these conditions. And again, don't worry about the details here, but what you can see here is that some of these bacteria that are noted here, if you have high levels of the bacteria, you have low levels of IBS. If you have high levels of the bacteria, you have less fatigue. And if you give people a fecal microbial transplant, which we'll talk about soon, i.e. you give people someone else's poo into their bowel, sorry to be gruff with this, then you end up increasing the concentrations of some of these bacteria, which is sort of exciting because maybe you could treat people and that might make things better. So what's been observed is that in people with myalgic encephalomyelitis, chronic fatigue syndrome, there are changes in bacteria that we know are present, and that these all interact with each other, and that this can lead to lower concentrations of short-chain fatty acids compared to people who don't have myalgic encephalomyelitis, chronic fatigue syndrome, and that this is associated with symptoms. So maybe if we can target some of these bacteria, we can improve short-chain fatty acids, and that may make people feel better. Let's have a look at this now. Can we do this? So this is an interesting study, review done, and what they've said in the study is trying to put together the gut microbiome in MECFS and trying to understand how the microbiome could potentially cause or could be treated in a way that might potentially help people with MECFS in some way. So what they did is that if we think about why people get MECFS, they noted a dysfunctional immune system, that there are some issues with energy production and oxidative stress. There may be some genetic predispositions and neurological abnormalities, but there's been dysbiosis identified, but there's been not a consistent signature where the same things are found all the time. And one of the problems with the microbiome studies is that people do it in many different ways, and also depending on what you're eating and what other drugs are going on, that can impact the microbiome as much as a condition can itself. So there's a lot of confounders and it makes it hard to understand. We know that the gut and brain interact with each other through the microbiome, and that communication occurs via inflammatory proteins and also through neurotransmitters and all these different ways. So gut and brain communication in MECFS is really important, and that actually the microbiome can actually impact on many of these things here. So there's a good reason why the microbiome could be important in MECFS. And other observations that have been made are that the gut may be more permeable. So the gut's a membrane, if you like, that tries to keep bad things out. And there's some suggestion that the gut may be a little bit leakier in people with MECFS. And then there's some other theories. There's a D-lactate lactic acid theory. I'm not going to go into these and these other theories that suggest that that this may increase problems. And again, antibiotic intake may also potentially increase the risk of MECFS, particularly if it's associated with infection. So there's lots of background theories that suggest that this could be important as well. So if that's the case, what could we do? Are there some studies that we could do in people with MECFS that may enable us to change the microbiome, improve short-chain fatty acid production, and maybe make people feel better and improve symptoms and be used as treatments in that way? So when it comes to changing the microbiome, we're sort of limited in the different ways that we can do things. So we can give probiotics. So a probiotic is a bacteria that has a positive beneficial effect on the human body. And a lot of these are bifidobacteria, lactobacilli. Many of you will know about these if you see them in the health food shops or in yogurts that you can buy from the supermarket and other places as well. The problem with most of the probiotic studies is that the studies are really poor quality. And the reason for that is that we don't know whether some of the probiotics even make it to the gut if you swallow them. We don't know whether sometimes people don't measure the symptoms in the right way. Often the studies are very small and there's a variation in the way that the probiotics are made. But if you look at the studies in MECFS, there are some changes in inflammatory markers in people who get probiotics. There are some changes in anxiety in one of the studies, but there's no effect on the core symptoms of fatigue and exercise tolerance and those other things that people are mostly interested in. So it sort of sounds promising, but at the moment, the studies don't suggest a significant benefit from using probiotics in a clinical trial setting. There are some studies being done where people are being given short-chain fatty acids and other neuroimmunological diseases such as multiple sclerosis. No studies that I'm aware of yet in MECFS. What about fecal microbiota transplantation? So this is where we get the feces of someone else and we put them in someone with a medical condition to see whether we can change the microbiome, and by doing that, potentially alter the natural history of that disease and improve the outcome for people. So this sounds really gross and really weird, but this is something that people are looking at really, really closely at the moment. And just to give you an idea, when it comes to a condition called Clostridium difficile colitis, this is a fantastic therapy. So these people who have this colitis can be very, very unwell, and having a transplant in this way can be a very effective way of managing it. There's also some limited evidence from studies of ulcerative colitis, of IBS and metabolic syndrome that there might be a benefit. So there are two studies that I've found looking at these two studies plus one more, which are looking at FMT in MECFS patients. So the first is from Tom Borody, who's based in Sydney. He gave rectal FMT, so that's an enema. The FMT was made from donated stools from people who are otherwise healthy. And he described 70% having a transient and 58% having a lasting benefit. Now, this is an uncontrolled study. There's no placebo. There's no control here. And Tom Borody's published a range of studies in a range of disease conditions where there's been excellent benefit in uncontrolled studies, but not always as much benefit when there's a control involved. So this is a really important observation, but it doesn't mean we should all be going out and recommending this for patients. The next study below there is with 42 patients with IBS, and this is a retrospective study. So look back at people who had already had this in the past. People were given either pre or probiotics for 10 days or FMT every day for 10 days in the form of an enema. And there's a description of a massive improvement on 17 of the 21 people who received FMT. So that sounds pretty good. But again, it's not controlled. And there's no randomization, it wasn't blinded. So there's some issues with the quality of these studies, but still important studies nonetheless. This study is out in July, just been published. So it's hot off the press. Now, this study is very good from its design point of view, but it's very poor because it's a small study, but it's only a pilot study. And what they're trying to do is to determine if you give people fecal microbial transplant, can you get a benefit on chronic fatigue? But it's a prospective study. The patients and the doctors were blinded. They didn't know whether they were getting placebo or the treatment. And patients were given either FMT with a donor transplant, or they were given their own bowel motion back. So it's a pretty good placebo, if you like, and that people didn't know what they were getting. They had a colonoscopy, and the FMT was given through the colonoscope. And the patients were the same in the two groups. But what they showed was that in this very small study, there was no significant effect on a range of different ways that you measure quality of life and other scores. And essentially, these changes in different aspects of the 15D scoring system were the same at baseline 1 month after FMT and 6 months after FMT in both the treatment and the placebo groups. So it didn't show any benefit. It doesn't mean we shouldn't be doing the studies, and shouldn't mean that we shouldn't be looking at FMT, but we need to try and understand why the study didn't show what we might have expected. How else could we change the microbiome in people with MECFS? Well, we could change the diet. So if you look at patient populations with MECFS and ask them about diet, about half people with MECFS will say that if they change their diet, they will get a reduction in fatigue. But the diet are limited, and I think there might be another speaker, hopefully, I don't know, Rose, whether Catherine Wall might be able to talk to you at some point about supplementation and those sort of things as well. But I'm not going to go into this just now, but certainly, clearly it's another way that we can easily change the microbiome, and perhaps a bit more tastefully than having a fecal microbial transplant, so to speak. So this is, again, another figure that puts together what might be going on. So maybe someone gets an infection, inflammation occurs, that may change what's going on in the gut, that may change the microbiome, and stress may play a role there as well. There may be a change in gut permeability, and things may get across. That may cause changes in the metabolism, and that may affect the brain and cause the cognitive CFS symptoms that occur subsequently. And the therapeutic options, if you're looking at trying to change what's going on here, would be prebiotics, which are foods that can encourage the growth of probiotics, FMT, which is being studied, but doesn't really have the data behind it, or diet, which would be the ways that could be looked at. So my question would be, does this look similar to an IBS? So this is a paper that I was involved in. We published a couple of years. Student Katerina Karko. And I just want to pull out a few of the diagrams, and don't look at the details, but just look at the broad areas. So on the left here, short chain fatty acids in IBS. Yes, they improve immune function, reduce inflammation, improve the barrier. So again, short chain fatty acids play a beneficial role in IBS and probably in MECFS as well. What about dysbiosis? Yes, in post-infectious IBS, you get dysbiosis, which are similar changes that you see here to what you see in MECFS. Lots of different factors involved. Yes, microbiome, permeability, immune activation, hypersensitivity, etc. Again, several of these things are things that you might see in people with MECFS as well. And immune cell activation. Again, we know that there's evidence of immune cell activation in ME/CSF, and again, we're seeing the same thing in IBS as well. And then how does food and digestion fit in? Well, yes, we can get fermentation of fiber, we can get changes in protein and lipids, and this can all cause hypersensitivity and symptoms that people get. And I certainly believe that through short chain fatty acids in particular, but also some of these other metabolites, we could be seeing similar things in people with ME/CFS as well. So I think there are a lot of similarities. So there are a lot of slides there, and I'm sorry that I've gone through them rather quickly, but I wanted to leave some time for discussion. As I said at the start, I'm not an ME/CFS expert, but I've really enjoyed reading about it. It's been fascinating for me to see the similarities with a number of gut disorders that I look after. I think that we need to learn from one disease and translate what we learn from one disease into another, because there may well be, some of these things may be the same disease, but just with manifestations occurring in different parts of the body. We don't know that yet, but I think as we understand the microbiome and what's going on, we may be able to identify that. And I think the changes that we see in the microbiome in both IBS and MECFS are seen in both. But one of the problems we have, of course, is that once someone has a condition, and if you look at their microbiome, it's a bit of a chicken and egg problem. So was it that the microbiome changed and that changed that led to the disease, or was it that they developed a disease and then their microbiome changed because of that? What we would love is longitudinal studies where we know what's going on in the gut before people develop the condition, but they are really difficult studies to do. I think we can now do look at amazing data sets with these multi-omics approach, looking at genes and proteins and all sorts of stuff, but we don't really know how to interpret it. And I think that microbiome is influenced mostly by diet, and I think that certainly should be a target for therapy for many of these conditions. I'll just remind you that I'm a trustee of the Gut Foundation, and that's how Rose found me. But otherwise, I'm really happy to take and have discussion about this, if that's okay.
Thanks so much for that walkthrough. It's a lot of material there, but definitely increased. No, it's awesome, increasing our understanding. So that's what we're keen to have. Has anyone got any questions now? Feel free to raise your hand or unmute yourself and ask the question.
Yeah, Rose, I have a question. If someone has like a lot of gut problems, and one of us has a lot of gut problems, like what avenue do we go down to start addressing some of those? Do we just see our GP, knowing that sometimes they don't understand MECFS or a lot of these IBS sort of things, or do we go see somebody else? Like, what's the avenue for starting to address these problems in ourselves?
Yes, I think the first point of call GP, and the reason for that is that they'll understand your gut symptoms in the context of other aspects of your health as well. Remember that while I've spoken a lot about IBS today, people with ME, CSF and other conditions can also develop other things. So, people can get celiac disease or, or other things too. So it's important that someone is there to ask about the alarm symptoms, the things like rectal bleeding, unexplained weight loss, severe nocturnal symptoms, family history of these things. That all needs to be taken into account. And while to get IBS, they might have other things too. So I think the GP is a good port of call to start with that. Be that their investigation, simple blood tests or fecal tests, or it may be a colonoscopy, but it needs someone to make that decision up front. Once it's been decided that the gut symptoms are more likely to be functional, so in the IBS realm, if you like, then it comes down to treatments are most likely to be helpful in that situation. So certainly there are some diets that are effective for IBS, and they could be tried in people with CFS, particularly if IBS is the driver of the symptoms in people with that condition. And so I think that's a good starting point. There are some medications that can be, but it's about probably firstly trying to make sure, is there anything else to be worried about? Yes, no. If no, then let's manage this as IBS to start with. Let's do these things. Then if we're not getting anywhere, is there a referral or someone else involved in what's going on? Question.
Thanks.
So there's a question on from Natalie. What is your take on gut biome testing? We know there are pros and cons, but what are your thoughts on those? So great. About a month and a half ago, I was part of a podcast for consumer based on this. The whole consumer series of podcasts was about changing the way that healthcare is now delivered. And I've seen the gut microbiome testing, and I've had patients bring it to me. And I currently do gut microbiome testing in a research setting for people where I'm doing studies of IBD or IBS, trying to understand changes in the microbiome and how that may mediate how people end up going. I think it's a fantastic thing. In time, it'll tell us an awful lot. But right now, I think my quote from that podcast was, I don't think it's ready for prime time. I don't think to patients and consumers in the population. I don't think that there's sufficient information in there that would justify spending $300 or $400 on a microbiome profile. We know that we can't interpret that microbiome profile for a given individual with any massive certainty. And the reason is that we can't define what a perfect microbiome is at this stage. We know that in certain diseases, there may be increases in some bacteria and other across the whole population. But for a given individual, it's very hard to make that suggestion. And really what we'd be saying is that having a diet that increases good bacteria, increases short-chain fatty acids is probably a good thing. It's probably a good thing to do regardless, if that makes sense. So Rose, a client sent this question, and I was referred to Christchurch Hospital for assessment after a scan a year ago. That I have an inflamed bowel, but I'm still on the wait list to be seen. Is there anything I can do to reduce the inflammation? Should I be concerned? So if you have an inflamed bowel and you haven't been seen, then you should hospital and or through your GP to try and get clarity on how it is. Post-COVID, things haven't been good. Already we're behind and not help, but we are increasing capacity, and I would hope that we can see you in a way that would be reasonable. Is there anything you can do to reduce the inflammation? It depends about what sort of inflammation. I think that if it's inflammatory, that's quite a different situation to if it's mild inflammation. So it depends on the details. But my thing will be, if you're on the waiting list for something and you haven't heard, contact them, and then get back to your GP and rattle cages if you need to do that.
Any other questions there?
I've got a question. I don't have IBS, but I had bowel cancer at the age 39, and I was a very healthy young person. It's quite alarming to see the high stats of people getting bowel cancer, and the younger and younger they're getting. Do you think the nitrates in the water may have something to do with this?
Yeah, really good question. I'm really sorry to hear about your experience as well. And you're right, we are still growing groups of people with bowel cancer as younger people. And that's really sad for people who are affected. It's also absolutely terrifying as someone who has to triage referral. Although younger people are now becoming to develop bowel cancer, they're still less likely than older people. And in a health system where there's a constrained resource for colonoscopy and things, something that can count against people if other symptoms aren't in keeping with bowel cancer. So it's a real problem. It could be the I don't think we know. I think that anything could be the cause of it. We have to be careful with what we call ecological data, which is where two things happen at the same time. So if you see a graph and both things graph at the same time, that's association or correlation, but not causation. And in that situation, we need somehow to understand, could there be something going on which suggests that. Now, there have been some studies done from Europe, which does associate concern around that. But I don't think we can say categorically it is the cause, but it's also a challenge. It's the cause as well. So it's a good thought. Others have thought it as well. There's also other correlations, Western diet, meat consumption, a whole range of things. And also for a given individual, one of those things, there might be 5 of those things. So it can be difficult, but it's a really good question.
Thank you.
Natalie, what are your thoughts about the gut skin axis? Are there severe skin issues around the gut? And is this your thinking? So there are definitely fairly documented gut skin things that go on together. So 9 of those would be, firstly, in celiac disease, there's a condition called dermatitis herpetiformis, which can cause a scaly rash here. There's also a condition in Crohn's disease and ulcerative colitis. People can get erythema nodosum and pyoderma gangrenosum. Sorry to rattle off bad-sounding Greek and Latin names at you, but all those things are associated. And certainly, if you talk to patients, they'll often say, "We'll have occurring at the same time as our gut problems. There's another SIBO, or small intestinal bacterial overgrowth, where you have a high concentration of bacteria in the small intestine that can lead to changes in the way you digest food and gut symptoms. And people with that have got an increased risk of acne rosacea, so that sort of red acne across the cheeks. So yes, there are absolutely gut-skin interactions. I think they're less well defined, but if I listen to my patients, they'll often will correlate changes in pre-existing skin problems with what's going on in their gut.
So, just calling for final questions. Oh, here we go.
Wait a moment. Richard, with regards to IBS, would probiotics and short-chain fatty acid supplementation and butyrate act synergistically? Is one better than the other in terms of theoretically reducing symptoms? So one of the issues with short-chain fatty acids is that if I gave you a glass of butyrate, you'd probably just about smelling it. So it's something that's pretty to take. So if we can get bacteria inside you that do it for you, that's probably a good idea. Short-chain fatty acid supplementation may be possible, but it's also about getting it to where you need it. And if it's in capsules and things, it's about, does it actually reach there? It'll be mostly from the health food and just from health food shops and things like that. And you've just got to be very, are their claims of what they do actually true? Or but I think that we don't know the answer to would both, but it depends on how well they're delivered. So Sue, you've had norovirus and it's trashed you. Yep, I can understand that. So we have people with IBS. I always tell them there are 3 triggers for IBS: gut infections, stress, and diet. And different people have got different amounts. And when I say gut infection, what I tell people is that their gut is hypersensitive to anything going on within it. And if you get it worse than everyone else. And I think that IBS things are part of the same thing. Hopefully that's what you've heard from me today. And I'm not surprised that norovirus has really crashed your other symptoms, because and they will be working through the microbiome, making changes in some of the things that I've suggested. So I think that would be an observation that in my clinical observations I've seen in IBS would be completely what we might expect.
Okay, well, I think, oh, hang on, here's another question.
Can I get a fecal transplant in New Zealand? So yes, you can. That from the studies, well, from the only randomized study I've shown you, that the jury's still out. So I think you'd have to accept that there's no guarantee. I think for many of us with many conditions, there are never any guarantees. Also understanding whether there's a downside or potential side effects to that. I know that Richard Everts, and who's a physician in Nelson, I think offers fecal transplants for a range of conditions. I'm not sure whether MECFS is one of those or not. So a microbiologist and infectious disease physician who works in private practice there. We do provide them. We don't do them. We're not involved in the treatment ourselves in gastroenterology in Christchurch, but we do the Clostridium difficile.
Sorry, can you just repeat that? You just went.
Yeah, sorry. So we do offer transplants, or we don't, but they are offered to people with refractory Clostridium difficile. So I mentioned that in the talk. That's a clear indication for that. But the other soft indications, and they wouldn't be offered in the hospital for that, but they are offered out of the hospital. But you'd have to go into it with no guarantees. Also understanding if there's a down.
I think, as you said, we're all individuals, and we can research possible treatments that are helping a subgroup of people, or appear to be helping a subgroup of people with MECFS. But everything we try, it needs to be a case study for ourselves, really.
Yep, and that's what I often say to people in any disease when they come and see me about Crohn's or whatever. They say, well, what about this? I say, well, might work, might not, but remember that, the only way to know for sure, I say for supplements, for example, is take the supplement for a while, see how you are, stop the supplement. If you get worse, start the supplement again, see if you get better. As an N=1 experiment, there's been a really great association. That's the case with starting and stopping, and for you, it's probably the thing to do. And remember, these things often have a cost as well, which is a side effect or adverse event that you need to be aware of. So people shouldn't take things blindly if they're not sure it's helping.
Yeah. Well, I think we've really enjoyed hearing what you've had to say, Richard, and really grateful that you've taken the time to join with us.
Thanks for the invitation.
And so thank you very much.
Okay.
Bye.
See you later. Thank you.
Bye.